This is Reed Pyeritz, the William Smilo Professor of Medicine and Genetics at the Perelman School of Medicine at the University of Pennsylvania. In this presentation, I will be discussing our current understanding of the etiology and pathogenesis of the Marfan syndrome. This has evolved over a period of several decades, but in order to understand cause, one has to understand clearly what the proper diagnosis is. And this has evolved over a much longer period of time, dating from the late 19th century. Our understanding of the pathogenesis has been relatively recent and overturned much of the underpinning of the notion of Marfan syndrome being a connective tissue disorder. Understanding of cause has implications not only for Marfan syndrome, but for many other conditions that affect the thoracic aorta. In 1896, Antonin Marfan described a young patient who had long limbs, scoliosis, and contractures. He termed this dolichosteomelia. Subsequent authors who probably did detect people with true Marfan syndrome labeled them Marfan, even though, as we now understand it, Marfan's original patient had a different condition, contractural arachnodactyly. The clinical features of Marfan syndrome evolved over much of the early 20th century, with the hallmark aortic conditions not being described until 1941. Marfan syndrome was recognized as being an autosomal dominant condition, likely due to a mutation in a single gene in 1949. Here's an X-ray of the first patient detected as having aortic root dilatation by Bayer, Taussig, and Oppenheimer. Victor McCusick, a cardiologist, was the first to codify diagnostic criteria in a paper in 1955, and he also was the first to describe Marfan syndrome as a heritable disorder of connective tissue. The cardiovascular features certainly are impressive and include progressive aortic regurgitation due to dilatation of the sinuses of Valsalva, and aortic dissection, typically involving the ascending aorta, which can lead to all of the typical complications of acute dissection. The hallmark pathologic finding in the Marfan aorta was originally called cystic medial necrosis, but since there are neither cysts nor necrosis present, the better term, which is in universal use today, is medial degeneration. However, this pathologic finding can be seen in almost all heritable disorders affecting the thoracic aorta, and indeed as a concomitant of hypertension and aging. The typical features of Marfan syndrome, which were known to McCusick and those of us taking care of patients in the mid-20th century, are tall stature with particularly long limbs, dislocation of the ocular lens due to stretching of the zonules, and as we've discussed, the typical cardiovascular features. Life expectancy was documented in 1972 as being markedly decreased, and in almost all cases due to complications involving the thoracic aorta. Here we see the life expectancy for females and males with Marfan syndrome compared to the normal United States population in the early 1970s. Most gratifying has been a variety of methods for treating complications of Marfan syndrome, particularly in a prophylactic way, beginning with composite graft surgery in 1969 and the use of prophylactic beta-adrenergic blockade. Further progression of aortic surgical techniques have certainly improved the outcomes and have led to the use of prophylactic surgery at earlier and earlier times. We'll also discuss how fibrillin 1 was identified as the causative agent and mention in passing how various clinical trials of other medications have been ongoing. Aortic management before the mid-1970s was expectant, and as Osler said, led to a very hopeless prognosis. Hugh Bentall described the composite graft in 1968. He's shown here with Vincent Gott, chief of cardiothoracic surgery at Johns Hopkins Hospital, who, among others, was the first to apply composite graft surgery to Marfan syndrome with quite gratifying results. The threshold for performing prophylactic surgery has decreased progressively as both technique and life expectancy have improved. These data show the findings from Johns Hopkins at the end of the 20th century, and showing here the life expectancy out to 2 decades for patients who had completely elective repair. And of course, Stanley Crawford taught us how to repair the entire aorta, typically in the setting of an acute thoracic aortic dissection that extended throughout the entire aorta. And this has been applied progressively in people with Marfan syndrome and other thoracic aortopathies. So with the increased awareness, regular follow-up, various medical management, including reduction in exercise, beta-adrenergic blockade, and prophylactic surgery, the life expectancy has improved from what it was in the 1970s to what it was in the mid-1990s for both women and men. I mentioned that McKusick first characterized Marfan syndrome as a heritable disorder of connective tissue, and that's where the search began for a cause. And in connective tissue, there are collagens, elastic fibers, which have multiple components, and a variety of proteoglycans and other biochemical substances. The locus was first mapped to chromosome 15 by Leena Peltonen and her group in Finland in 1990. And here we see Leena Peltonen with Vincent Gott and Hugh Bentall and Victor McKusick back in the mid-1990s. Here are the pedigrees that Professor Peltonen used to map the locus for Marfan syndrome to this region on chromosome 15. Our group also performed linkage analysis on a large pedigree from Kentucky and also confirmed that the locus was on chromosome 15, but put it at a different location right here at band Q21. So then it became an issue of what genes at that locus on chromosome 15 could be potentially causative of Marfan syndrome. Simultaneously, biochemical studies were being performed, and in these 2 studies of both tissue and of cultured fibroblasts, an antibody for the protein fibrillin 1 was used for staining, and showing that the patient with Marfan syndrome here had marked reduction of fibrillin 1, and in cultured fibroblasts of this patient here, there was also marked reduction of the production of fibrillin 1. So then it became an issue of actually mapping the fibrillin 1 locus, and this was achieved in 1990 by fluorescent in situ hybridization that showed that the actual gene was located here at band Q21 on chromosome 15. So then the issue became actually detecting mutations in fibrillin 1 in patients with Marfan syndrome, and this was accomplished by Hal Dietz in collaboration with a number of us at Johns Hopkins. And in this patient and a similar patient, a mutation was found in her DNA in the gene for fibrillin-1. And this is the group at Hopkins that was responsible for this first detection of a mutation in fibrillin. Fibrillin is a very large protein, a component of the elastic fiber, and it spans a considerable region of chromosome 15 and has similarity, homology, to a latent transforming growth factor binding protein, which is capable of associating with fibrillin-1. There are any number of mutations in fibrillin that can cause classic Marfan syndrome. This is an early depiction of this, and there are now over 1,000 mutations in fibrillin-1 associated with classic Marfan syndrome. And these mutations occur throughout the fibrillin-1 gene. Mutations in this middle region tend to produce a phenotype that is consistent with the severe form. And unfortunately, for the detection of Marfan syndrome mutations, changes in the fibrillin-1 gene can be associated with other conditions, including those that share only a few features of Marfan syndrome but do not cause the full phenotype, and quite surprisingly and strikingly, conditions that are the antithesis of Marfan syndrome, including Weill-Marchiazzoni syndrome and geophysic dysplasia, which are forms of dwarfism. So once the gene was identified and fibrillin-1 was understood to be defective in Marfan syndrome, this was consistent with the notion of a heritable disorder of connective tissue, because fibrillin is intrinsic to elastic fibers, which provide both structure and elasticity to many tissues. However, this did not explain how excessive growth would occur, and some other features also involved in classic Marfan syndrome. So the whole notion of this being simply a heritable disorder of connective tissue was brought into question. Then, in studies spearheaded by the Dietz group at Hopkins, the notion that fibrillin was involved in the regulation of transforming growth factor beta signaling became highly interesting. And in this study by Enid Neptune in a mouse model of Marfan syndrome, you can see that the mouse with the severe form of Marfan syndrome had failure of development of the terminal alveoli in the lung. And as we know, spontaneous pneumothorax is a frequent occurrence in people with classic Marfan syndrome. Most strikingly, when the mouse lung tissue was stained for transforming growth factor beta signaling, there was excessive signaling in the mouse that had the fibrillin gene knocked out. When the aortic wall in these mice was compared to wild-type mice, the Marfan mouse had very striking abnormalities consistent with medial degeneration, but also with thickening of the aortic wall. In the mouse treated with propranolol alone, there was some benefit, but not very much in terms of the architecture of the aortic wall. However, in the mouse with classic Marfan syndrome treated with losartan, an angiotensin receptor blocker, there was normalization of the thickness and architecture of the aortic wall. Now, angiotensin receptor blockers are known to interfere with TGF-beta signaling. This led to a new perspective on the pathogenesis of Marfan syndrome, and the hope that understanding this would provide a new model for medical treatment. To this end, a large multi-center trial was funded by the National Heart, Lung, and Blood Institute in the early 21st century, involving patients who met classic Marfan syndrome diagnostic criteria, who were young and had substantial dilatation of the aortic root, meaning that the Z-score was +3 or greater. These patients were randomized to either take atenolol or losartan for a period of 3 years. 608 patients were randomized. When the data were analyzed, it was seen that atenolol and losartan had no statistically significant difference in beneficial effect. Unfortunately, no placebo group was involved because patients could not be recruited who would be willing to take only a placebo for 3 years. Thus, current medication remains either beta blockade or angiotensin receptor blockade, and knowledge of the pathogenesis has not directly led to improved therapy. So what is to come? Well, the prognosis is based on our understanding of natural history, which is what occurs in the absence of medical or surgical intervention, and clinical history, which is what occurs when medical and surgical therapy are applied to patients. Both of these forms of study are crucial to determining what will occur and what life expectancy will be like in patients. Most of the aspects of natural history are age-dependent, meaning that the phenotype emerges over time. This is certainly true of the aortic dilatation, the development and progression of mitral regurgitation due to mitral valve prolapse, and then the occurrence of aortic dissection. Interestingly, as the clinical history improves, meaning that as patients live longer, new aspects of natural history will emerge. And so it's very important that we continue to observe and record the evolving phenotype of patients as they live longer. As milder forms of conditions involving aortopathy are recognized, many patients will be diagnosed later in life, and these patients will often have findings that are rarely seen in younger patients. So features of Marfan syndrome that only relatively recently became clearly identified with the condition, and for which the pathogenesis is still completely unclear, includes dural ectasia, where large dilatations of the lumbosacral spinal canal, including the development of anterior meningoceles, has been recognized as a very frequent feature. Here you see the dilatation of the spinal canal and the anterior meningoceles, which can certainly have lifelong neurologic complications that can be quite disabling. Additionally, cysts in the liver and in the kidney are frequently seen, often serendipitously when patients are being imaged for their thoracoabdominal aortas. It's important to note that these cysts are not deleterious as far as we understand in the development of any complications, but they should not cause undue consternation on the part of the physicians or patients themselves. Again, the pathogenesis of these unusual findings is not at all clear. So again, the future of natural and clinical history are important to follow, and both will provide control populations for clinical studies of other rare disorders. So here is a list of the later onset problems that have been identified in Marfan syndrome. We have an understanding of the pathogenesis of the cardiovascular features. The ocular features are still inscrutable. Certainly, the ectopia lentis is likely due to weakening of the connective tissue involved in the zonules that hold the lens in place. However, the development of cataract and glaucoma are not at all understood. Skeletal problems such as degenerative arthritis and osteoporosis are extremely common and should be carefully monitored and treated as necessary. The dural ectasia can cause all sorts of neurologic complications. We mentioned pneumothorax, but there are also other complications involving the pulmonary system, development of restrictive lung disease, and sleep apnea. And of course, we always need to focus on the psychologic impact of a serious disorder on patients and their relatives. In conclusion, I would like to acknowledge all of my collaborators over the years at both Hopkins and the University of Pennsylvania, the National Marfan Foundation, which is now called simply the Marfan Foundation, and a number of registries that have been essential for recording data and maintaining biorepositories that have been greatly influential in understanding etiology and pathogenesis. Thank you.